Oncology Stewardship at your institution. For this session, we have Dr. Manzoor Khan with us. He is currently working as a senior clinical pharmacist covering oncology, hematology, BMT at the Ministry of National Guard Health Affairs, Jeddah, for the last 16 years. After graduating from the University of Punjab, he worked as a clinical pharmacist at Shaukat Khanum Cancer Hospital and Research Center. In the meantime, he completed his master's in clinical pharmacology and therapeutics. He also obtained his BPS certification in oncology in 2010 and recertification in 2017. He has published more than 20 papers in peer-reviewed journals, and he has also established oncology clinical pharmacy services in Princess Noura Oncology Center. So looking forward to learn from you, Mr. Manzoor.
Assalamu alaikum wa rahmatullahi wa barakatuh. Good afternoon, everyone, and good day, everyone. I would say we have people from around the globe. Thanks, Busha, for the nice introduction. Thanks giving back to Pharmacy in Pakistan for having such a beautiful conference again here with the third edition. I don't have any disclosure. So, Busha, I think we're running out of time. So, because of positive time, I would suggest that you should remind me after 14 or 15 minutes into my presentation so that I don't take longer than the allotted time, okay? And actually, I'll take lesser than the allotted time, actually. So these are my objectives. We'll try to talk about the objectives of the Oncology Stewardship Program. And by the end of the presentation, I hope that the audience will be able to understand the value of the stewardship in oncology. We're going to elaborate it a little bit more in the next couple of slides. And they'll be able to assess the current gaps and challenges in implementing stewardship in oncology. And they will be able to understand the role of pharmacists in activating the stewardship in oncology.
Sir, could you please share the slides, please?
You did not see my slide? I think I have shared my slides. I guess I have shared my slide. You cannot see my slides?
No, sir.
What about now?
Yes, sir. Alhamdulillah.
Okay. I think there's a glitch today from my side. I don't know from the other side. So these are my objectives. I think we talked about the objectives. So in order to understand the Oncology Stewardship Program, we have to understand the background of the Antimicrobial Stewardship Program, because Antimicrobial Stewardship Program has been the standard of care in the tertiary care hospital in infectious diseases. That's an integral part of infectious disease management. And we obviously all know the benefits of Antimicrobial Stewardship Program in terms of reducing the resource utilization. It reduces the cost and it reduces the drug resistance pattern and improves the quality of life of patients, and definitely keeps a lot of options in the arsenal when it comes to treating infectious diseases. A similar kind of program need to be designed in oncology, and the magnitude of the benefit in terms of resource utilization and improving quality of life will be many-fold higher than what we have seen in Antimicrobial Stewardship Program. So this kind of program have not been universally implemented in oncology up until now, although there are some centers in the United States who have implemented, and we have a plan to implement a similar kind of Oncology Stewardship Program at Ministry of National Guard Health Affairs in Saudi Arabia, and I propose that we should do this kind of program in Pakistan, and I'll talk about that why. So one of the objectives of our presentation was to understand and elaborate the value of the Oncology Stewardship Program. So one of the key elements, or the key objective, the key outcome of the Oncology Stewardship Program is to reduce the financial toxicity, improve the safety and efficacy of the regimen, and try to make sure that what we use regimens in oncology patients are cost effective, and that improve the health-related quality of life of patients. So what is financial toxicity? This is the terminology which is used internationally in North American and European papers, in the international guidelines. And this is definitely touched upon in the literature recently. And this is basically a distress or hardship which is experienced by the cancer patient and their family member due to the financial burden of the cancer treatment. So let's have a look at the impact on the cancer patient. So in the United States, according to this report, there have been nearly 20 million cancer survivors, and about 1.4% of these patients have been declared bankrupt, which is amounting to 275,000, and 1.7 million patients are reported making other financial sacrifices. Compare this with Pakistan, our resource-limited countries such as South Asia. This percentage of bankruptcy are reported making the other financial sacrifices is many-fold higher than what we have seen in the United States. Remember, the United States is one of the richest economy, around the globe, and they have the best healthcare system in the world. But in Pakistan, where the cancer treatment is actually not afforded by the government, the public sector, most of the time people pay out of their pocket. So it's a multi-layer payment structure where the patients are not only sacrificing their own assets for the management of the cancer, but also they are using the pooled resources of other family members. And when it comes to the public sector, they are using the pooled resources of the other public sector. And financial toxicity can be divided into two major categories: objective financial toxicity and subjective financial toxicity. Objective financial toxicity is related to the direct cost of the expenditure related to the oncology care. But the subjective financial toxicity, which we always not talk about, that we don't consider that, but that is very significant. And that is hidden cost associated with the treatment of the cancer, where, for example, cancer patient cannot go for the cancer cannot go for the job, and the family or the caregiver of the cancer patient will also be staying with most of the time with the cancer patient, and they will also not be able to go to the job. So they will not be able to get the salaries or wages, and that will result in, again, sacrificing the assets of not only the patient, but also the family members, and that results in significant anxiety and discomfort. So that's the financial toxicity, which we would like to cover in Oncology Stewardship Program, and would like to reduce the impact of the financial toxicity in resource-limited countries such as Pakistan. And not only this, I mean, financial toxicity, when we talk about reducing the financial toxicity, we're not compromising the outcomes of the treatment. We try to make sure that the treatment that we use is going to be cost-effective treatment options, reducing the financial toxicity and improving overall health-related quality of life. How can we implement Oncology Stewardship Program at your center? And we have planned this Oncology Stewardship Program at my center in Ministry of National Guard Health Affairs with the 4 points. The first point is a cost-effective formulary management, including the class review. So when you have a request from physician to add a certain antineoplastic agents or target therapy to be added to the formulary, try to review the cost-effective formulary management. So oncology pharmacists, physician, hematologists, oncologists, they should sit together and they should look at the outcomes. Not only that, they should look at other members in the class and try to see like which one is much more cost effective. I think we can talk about this in detail in another forum when we have enough time. And one of the key elements which we had seen in antimicrobial stewardship program, that was the development of the antimicrobial guidelines and drug use policies, and then trying to see the compliance to these guidelines. A similar kind of platform we need to execute in order to develop oncology stewardship program. So what we need to have is to have the develop and implement the clinical practice guideline, and try to have the drug use policies when we approve any medication into our formulary. We need to have the drug use policy, and then we need to do a lot of medication use evaluation in order to make sure that we are compliant with this guideline. And that's the hallmark, that's the true spirit of the Oncology Stewardship Program. If you can take back and have a look at how the antimicrobial stewardship program was implemented. One of the most important things which we don't consider as a pharmacist or as an oncology pharmacist in resource-limited countries, where there's a lot of need to do that in Pakistan, is the implementation of clinically meaningful outcomes. There are a lot of them, so we can go through them quickly. This is definitely important to use a medication which has a clinically meaningful outcome, so that if there's a financial toxicity associated with that, there is a value-based care. Dr. Ahmed Al-Bidai in the morning was talking about that, and we are approaching towards the implementation of the value-based care, and it's already been implemented in most of the centers in the United States. And the 4th point is the implementation of high-quality oncology generics and biosimilars to reduce the healthcare spending. Definitely, anything which reduces the healthcare spending without affecting the outcomes would definitely reduce the financial toxicity. I mean, oncology, high-quality oncology generics. In Pakistan, sometimes we don't have the high-quality oncology generics. We should try to make sure that the biosimilars we're going to use are high-quality biosimilars, because using high-quality oncology generics and biosimilars will not compromise the outcomes of these cancer patients. Another objective of my presentation was to discuss and elaborate the role of the oncology clinical pharmacists or oncology pharmacists in activating or implementing the Oncology Stewardship Program. And to be honest with you, one of the key stewards in the whole program is the pharmacists. So they have to play an important role in formulary management. I don't want to go into the details. They are part of the clinical pharmacists. They are part of the team which attend the tumor board meetings, and then they recommend cost-effective treatment options. And we do a lot of medication use evaluation in order to see how much we are compliant. And in my observation of 22 years of clinical experience in oncology, hematology, I believe that around 70 to 80% of the time we are providing supportive care to cancer patients. I mean, like either we are trying to prevent the complications of cancer, or we're trying to manage the complications of cancer or associated treatment, for example, febrile neutropenia, tumor lysis syndrome, etc. And if we recommend cost-effective treatment options for the supportive care, we are pretty much doing the Oncology Stewardship Program. We really need to involve the pharmacists in the cost of care discussion. I know people are doing this in Shaukat Khanum Cancer Hospital with my experience, and I'm sure other private sector, they are doing it. But we need to kind of involve more and more into the patient care discussion and tell them what are the outcomes for the different treatment options and what treatment is more cost effective for them, especially when they have to pay out of their pocket. I don't want to go into the details, but I just would like to take you and give you some of the examples from Ministry of National Guard Health Affairs formulary. So we do pharmacoeconomic evaluation of drugs, and we have been given targets, and we have been achieving targets of 100 million real saving every year. From 2018 onward, we do class reviews, MUEs. We even recommend treatment-free remission for chronic myeloid leukemia, and we published one of our paper like 1 week ago in Journal of Applied Oncology, where the patient go off therapy. Around 90% of patients in our study had shown they can go off therapy for lifelong, and the benefit, cost benefit, was about 7.5 million in 25 patients, which is doubling every year, every passing year, because this treatment was lifelong. And we have recommended treatment-free remission with close monitoring. Around 90% of patients that did not relapse, so they are going to go off therapy. So this is not only reducing the financial toxicity, but also reducing the physical toxicity burden and improve the quality of life and well-being of the patient. They can go off therapy, and these kind of things are not implemented in resource-limited countries in Pakistan, whereas these are being implemented in Europe, North America, Saudi Arabia, which are the rich countries. We need to do a lot of MUEs. So MUEs can help you in the cost-effective formulary management. I will skip it. Development and implementation of the clinical practice guideline, as I mentioned earlier, is the hallmark of the treatment. If you can have the guidelines and implement and try to make sure that more than 80% of the guidelines are implemented. So this is the main hallmark of the Oncology Stewardship Program implementation. If we can do that, we can say that we have implemented the Oncology Stewardship Program. Of course, the stakeholders, the P&T committee, and all of these parties need to be involved in that. Moving to clinically meaningful outcomes, what are the solutions underway? According to one of the position statements in ASCO, American Statistics in Oncology, published 5 years ago, there are a lot of solutions. What I am working on is ASCO value framework, oncology stewardship teams for Ministry of National Guard Health Affairs. The country Ministry of Health is working on value-based care. Dr. Ahmed Al-Jadai and his team is working on value-based and outcome-based pricing. I am working on Oncology Stewardship Program for the Saudi Arabia. And we definitely have the development of biosimilars and generics initiative already implemented. I'll give you an example of this medication, Regorafenib, which is used as third-line treatment option in metastatic colorectal cancer. Have a look at this correct trial, which was in the MAIA phase 3 control trial, which compared Regorafenib, one of the tyrosine kinase inhibitor, compared with the best supportive care. And one of the endpoint was progression-free survival, which is, you can say, only it improved PFS only by few days in the favor of Regorafenib. And have a look at the p-value. How misguiding is this? Less than 0.00001, and this is the part of the international guideline to treat a metastatic colorectal cancer patient in third-line treatment option, and it has significant toxicities. So these are the medications who do not meet the outcomes meaningful outcomes for treating cancer patients. And a lot of time people consult me from Pakistan about Regorafenib, about Sorafenib in HCC and advanced disease. So these are the medications which do not meet the criteria for clinically meaningful outcomes. And unfortunately, these poor patient population, they have to pay out of their pocket. Even if they are not poor, they are middle class, or even if they are rich, their resources are going to be depleted by using these kind of expensive and innovative therapies. And if they are not meeting clinically meaningful outcomes, then we should try to protect our patients. And we talked about high quality oncology generics. We have implemented biosimilars of all the blockbusters in oncology. How can we implement Oncology Stewardship Program in your country, in our country? So first thing is to establish a multidisciplinary stewardship team to run the program. And we need to select few diseases in order not to be overwhelmed. We can even start from one disease actually. And then we choose the regimen which are much more expensive and try to make sure that we use the regimen in a cost-effective manner. We need to have the clinical practice guideline and clinical pathways. For example, I have a plan to implement Oncology Stewardship Program in the Ministry of National Guard Health Affairs. So we have decided to go with 2 or 3 diseases. We would like to go with the breast cancer, which is the most common disease, and colorectal cancer, which is the second most common disease. And these are both for medical oncology. And for hematology, I have recommended to choose lymphoma because there are some regimens which are not cost effective and they can be used in frontline settings. And then we need to do the medication use evaluation in order to make sure that we are compliant with our guideline. And that is the hallmark of Oncology Stewardship Program. I'll give you an example of affinity trial here, which had been used in early HER2 positive breast cancer. So 2 anti-HER2 blockade, trastuzumab plus pertuzumab, was compared with trastuzumab alone. And the primary endpoint was the invasive disease-free survival. And you can see the invasive disease-free survival was only 1% better than the single agent, but that was associated with the financial toxicity of extra 400,000 real per patient for a very marginal risk reduction. So we do not recommend in Saudi Arabia, and we need to do the same in Pakistan. Similar was the Hodgkin disease Echelon-1 trial, where the brentuximab addition in the stage 3, stage 4 Hodgkin disease resulted in very mild improvement in progression-free survival of less than 5%. However, patients have to pay $500,000 extra. This is very significant financial toxicity, and the P&T committee did not approve this indication in many centers. However, people are using it because there is an Echelon-1 trial. So although there are recommendations of the international guideline, but we need to evaluate them carefully in a cost-effective manner, considering our resource utilization and considering the patient financial toxicity as well. So there are a lot of challenges. This is the second last slide. So there are a lot of challenges in implementing Oncology Stewardship Program. The first of all is there's lack of national guideline and consensus on clinically meaningful outcome thresholds. And we are anticipating significant resistance from oncology-hematology physicians, so we need to take them on board. And they have to be one of the key stewards, like, for example, in antimicrobial stewardship program. So the ID physician, ID consultants, they are the key stewards. So we need to similarly activate oncology-hematology consultants and physicians to be the stewards and take the heat of this program. And one of the key challenges is that we don't have enough competent oncology clinical pharmacy practitioner who may serve as the steward. And we conclude that implementing these 4 points, cost-effective formulary management, development and implementation of clinical practice guidelines, implementation of clinically meaningful outcomes, and implementation of high-quality oncology generics and biosimilars, we can reduce significantly financial toxicity without compromising the outcomes and improving the health-related quality of life. With that, thank you so much. And this is my email. If you have any question, you can send it to me. Thank you so much for your attention. Over to Dr. Siddiqui for the concluding remarks.
Thank you, Mr. Mansoor, for giving such a thought-provoking presentation. We rarely hear about oncology stewardship programs. Most of the times it's the antibiotic stewardship. So thank you for raising concern for such a neglected yet important topic in such a wonderful way. So it was an amazing experience as a moderator to work for the cause of pharmacists and introduce our worthy speakers.